Hello, my name is Dr. Melanie Bourgeot. I'm a fourth-year pathology resident at Emory University, and in this video I'm going to be going over 3 interesting cases in dermatopathology and soft tissue pathology. As usual, you can find the links to the digital slides in the video description. This is a resection of a thigh mass in a 26-year-old female. At low power, you can see we have a large mass that is steeped to the subcutaneous fat. And then if we look closer here, it is at least focally involving the underlying fascia. The lesion itself is composed of discohesive nests of large epithelioid to rhabdoid cells with eosinophilic granular cytoplasm. The nuclei are round to oval, and some have irregular membranes or grooves, like these here. Nucleoli are also easily identified, and some are even cherry red. There are also scattered cells with nuclear hyperchromasia and multinucleation. For instance, this multinucleated cell here, and this hyperchromatic cell here. Lastly, there are also numerous capillaries between these nests. Some are small and slit-like, like these here, while some are larger and dilated. This is an example of alveolar soft part sarcoma, which is a high-grade translocation-associated sarcoma that most commonly arises in the proximal lower extremity of young female patients. Histologic features of this tumor include discohesive nests of epithelioid to rhabdoid cells with abundant dense pink cytoplasm containing PAS-positive diastase-resistant granules. Alveolar soft part sarcoma has a characteristic unbalanced translocation involving chromosomes X and 17, resulting in a fusion between the genes ASPL and TFE3. Due to this fusion, cells have diffuse nuclear positivity for TFE3. Most cases are also positive for cathepsin K. However, this is not entirely specific and can be seen in granular cell tumor as well as picomas with TFE3 gene rearrangements. About half the cases are focally positive for desmin, which is a potential pitfall if a skeletal muscle neoplasm or picoma is in the differential. Fortunately, these tumors are negative for melanocytic and neural markers, such as S100, SOX10, MAR1 or melon A, and HMB45, which excludes potential histologic mimics such as clear cell sarcoma, melanoma, granular cell tumor, and picoma. This is an excision of a firm nodule on the lower leg of a 33-year-old female. At low power, we see this lesion is composed of variably dilated ducts within a dense fibrous stroma. The borders appear well defined, and there is adjacent subcutaneous tissue. Taking a closer look, many of these ducts have papillary projections, some of which completely fill the lumen and impart a solid appearance. Foamy pink material is also seen within the lumens. Taking a closer look at the ducts themselves, you can see that they are composed of a double layer of epithelium, with flattened small basal cells and columnar luminal cells, with amphiphilic cytoplasm and bland nuclear features. This is an example of papillary Eccrine adenoma, a rare benign sweat gland neoplasm, which most commonly arises on the distal extremities of adult women. Histologic features include variably sized Eccrine-type ducts with papillary structures, and a dense fibrous stroma, which may appear to encircle these ducts. The differential diagnosis includes other rare sweat gland neoplasms, such as tubular apocrine adenoma, which has apocrine instead of Eccrine differentiation, and tubulopapillary hydroadenoma, which has both Eccrine and apocrine differentiation. Digital papillary adenocarcinoma is also an important consideration. These lesions are usually composed of larger nodules with more architectural complexity and infiltrative growth. In addition, cells have at least mild nuclear atypia, and mitotic figures and necrosis may be present. Clinically, digital papillary adenocarcinoma typically presents as a nodule on the finger of a young adult male. The final diagnostic consideration is a metastatic adenocarcinoma, which will have typical features of malignancy such as infiltrative growth, nuclear atypia, pleomorphism, and mitotic activity. In these cases, a complete clinical history is also helpful. This is an excision of a plaque-like lesion on the back of a 16-year-old female. At low power, we have an infiltrative mass located in the subcutis with focal extension into the dermis. If we take a closer look, we can see that there are two distinct and mixed components within the lesion. The infiltrative component, which I'll show here, is made up of fascicles of spindle cells within a collagenous background. The cells themselves are relatively uniform, with fusiform to oval nuclei, vesicular chromatin, and one or two punctate nucleoli. The cytoplasm is pale and amphiphilic, and the cell borders are indistinct. In contrast, the nodular component is well defined and composed of sheets of histiocytoid cells with similar nuclear features as the spindle cells. However, their cytoplasm is more of a dense amphiphilic color. There are also scattered multinucleated giant cells present. Lastly, both components contain areas of hemorrhage, hemosiderin, and a mild chronic inflammatory infiltrate. This is an example of plexiform fibrohistiocytic tumor, a biphasic soft tissue neoplasm that most commonly presents in children and young adults as a slow-growing plaque on the forearm or hand. This lesion is composed of nodules of histiocytoid cells, surrounded by infiltrative fascicles of spindle cells. To me, this is a pretty unique morphology. However, if you had a small biopsy lacking both components, it may not be as clear. In such cases, the differential would include fibroblastic and myofibroblastic tumors such as fibromatosis, nodular fasciitis, and fibrous hamartoma of infancy. In addition, the multinodular growth seen in cellular neurothekioma may mimic the histiocytoid nodules in this tumor. Immunohistochemistry is not especially helpful. The spindle cells in plexiform fibrohistiocytic tumor are at least focally positive for SMA, and histiocytoid cells are positive for CD68 and CD168, which honestly doesn't really rule out anything. Lack of staining for MITF could help rule out cellular neurothekioma. However, it's important to know that some cases of plexiform fibrohistiocytic tumor are focally positive. Clinical features such as patient age, location, and rate of growth can be helpful in the diagnosis, but additional tissue sampling may still be necessary. This usually isn't a problem, since complete excision is recommended, given its potential for metastasis, although this is rare. Local recurrence is more common and may occur in up to 40% of cases. And that's all I have for now. Please like and subscribe, and for more educational pathology content, check out my Mega Index using the QR code or link in the description. Thanks for watching.